Opportunity to present this case involving a patient with transcatheter mitral valve replacement in a patient who has already put a mitral ring on his valve. To begin with, we're dealing with a 46-year-old male who has severe symptomatic regurgitation and has gradually worsening effort dyspnea. His past medical history includes inferior STEMI, complicated with cardiogenic shock, for which an intra-aortic balloon pump was put, and then an urgent coronary angiography was made, revealing a proximal stenosis, severe stenosis of LAD and diagonal brasses, complete occlusion of the LCX and the RCA, which was the culprit lesion. And after that, an urgent percutaneous coronary intervention was made to the RCA. And after that, the heart team decided that the patient should do a bypass, and because in the pre-procedural echo, a moderate ischemic MR type 3B carpenters was revealed, they decided that during the surgery, an MV-plasty with a complete semi-rigid ring stimulus should also be placed in the patient. Although this happened, the post-procedural TOE revealed a mild to moderate MR. 4 months later, the patient, an ICD was inserted. The patient is also obese. He is an ex-smoker, and he has also a history of hypertension, dyslipidemia, COPD, and mildly impaired renal function. At the time of the investigation in our department, he is on optimal medical therapy at the max tolerated doses, and his ECG did not reveal an LBBB or a widening of the QRS, so he is not a candidate for an advancement to a CRTD. Based on all this, the calculated scores, surgical scores, was compatible with a patient of medium risk. So, in order to investigate our patient and see what we can do to fix his problem, the following exams were made. First of all, a coronary angiography that revealed that the graft was patent and there was no intrastenosis in the RCA. A screening right heart catheterization who revealed a mean pressure of 47 millimeters and a wedge pressure of 36 and the current output of 4.2. And of course, transthoracic echocardiography who revealed an impaired function of the LV with an LVEF about 30-35%, and dilated left ventricle with end diastolic diameter being 55. And as you can see, a severe mitral regurgitation due to a severe tethering of the posterior leaflet and anterior coarctation of the leaflet, as you can see better in these images. So the next exam was a transesophageal echocardiography, and this was mainly in order to assess if this patient is a candidate for edge-to-edge repair with a mitral clip. This exam showed again the significant mitral regurgitation and the tethering, and also showed that there is a significant coaptation gap of about 10 millimeters. So we decided that this patient would not be suitable for transcatheter edge-to-edge repair. So the next thing that we have to do is to see if this patient is a right candidate for transcatheter valve implantation. And to do this, we use this application, the valve-in-valve application, where we can put the measurements of the previously implanted ring, and the application can tell us if this patient is a candidate, and can tell us also the right measure of the valve that we can choose. After putting this on the application, the answer was that we can choose a valve of 29 millimeters, a sapient valve of 29 millimeters. So the next thing is to see, as we heard before, if the patient has high-risk criteria for LVOT obstruction. To do this, we again can use the app and put the measurements from the CT that was made in our department. And based on these measurements, the patient's risk for LVOT was low. So based on all this, the heart team decided that a transcatheter mitral valve implantation, valve-in-ring, with balloon expandable valve should be the optimal strategy for this patient. So these are, in short, the procedural steps that I'm going to tell you during the next video. And Mr. Iakovou, you can interrupt me and correct me whenever you want. And in general, the procedure was made under general anesthesia, and puncture of the femoral vein was made under ultrasound guidance.
Well, the main thing here is whether or not to plan a laboon technique, or because we were worried about the length of the anterior leaflet. So we measured its borderline, it's to ND2, as far as I remember. And I think, so we decided that it's safe to proceed without endangering a laboon technique. So that's why we proceeded, and you can proceed the same.
So now I don't have my notes, so I don't want the correct time of what I want to say, but I'll try to be as fast. Yes. No. So, okay. Don't worry, I'll try to. Yes, because they try to fix it, but it's okay.
As I can see, Dr. Perlepe has perfectly on the screen, so.
Okay, don't worry.
So it doesn't transmit to the big screen.
Don't worry. Έχω βρει τους χρόνους και τα έχω σημειώσει γι' αυτό, αλλά δεν έχω τις σημειώσεις μου για να μπορώ να το πω. Okay, now I'm okay. So, initially, as we can see here, I put the left femoral vein was punctured to allow placement of a temporary pacing lead, and subsequently, the left vein was also punctured. The right femoral vein was also punctured, and seats of 6 French and 9 French were first inserted, followed by an 18 French sheath. And also a 6 French prostyle closure device was also placed. So now, move on to something more interesting. Okay, here we can see that after vascular access, transeptal puncture was performed using an SL1 sheath and BRK1 needle. You can see also here the echo guidance for the puncture. So, upon successful puncture, Applerger super-stiff wire was advanced into the left pulmonary vein. As shown here. And the transeptal sheath was then removed. Here we're removing the transeptal sheath, and an Azilis steerable sheath was introduced. This is the Azilis sheath. Now, the Amplatz wire was exchanged, and two safari wires, one small and one extra small, as body wires, were positioned in the left ventricle via this Azilis sheath, as you will see now. Sorry. This is the one. Okay, the one. And now the second one. So after this, a temporal pacing lead was positioned in the right ventricle. As you can see here. It is placed. And the next step involved the insertion of the Edwards E sheath of 14 French through the right femoral vein. So, let's proceed. This is the sheath that I was talking about. Then an Atlas Gold of 20 millimeters balloon was advanced and used to dilate the interarterial septum. I will show you this step. This is the balloon. We dilated this balloon through two or three times under echo guidance.
Well, I think it's a 12 by 40 Atlas Gold. Yes.
It was 2040, yes. 12, 40.
Yeah, you use 12 or 14, mostly.
Okay, so this was followed by the preparation of the valve delivery system that I'm going to show you right now. This is the preparation of the delivery system. And then this was advanced carefully up to the level of the mitral ring. You will see it in a few seconds.
It's the opposite than the aorta. Make a mistake.
Well, but it happened. It happened, yes.
Okay, so you can see the valve through the system, the delivery system. It's reaching the mitral ring. So after confirming optimal positioning of the valve just in the center of the mitral ring, Rapid ventricular pacing was initiated. We started the pacing, you can see it. And in the next few seconds, you will see the deployment of the valve. The valve was gradually deployed, balloon expandable, until full expansion was achieved. It has some resistance, but at the end, the valve was fully expanded. You can see it here. So, color Doppler imaging showed a really satisfactory result with no regurgitation.
It's important that you do it slow as we did, because as the valve shortens from the base to the apex, you have to make sure that when it's half
Exactly.
that you can pull it back a little bit.
It has to be slow, and we had
it has to be very slow, exactly as you did it.
Yes, as you noticed, initially we didn't have proper pacing, so we had Dr. Leontiadis had to be really exactly meticulous and very strong in his in the inflation of the balloon, and I have to hold the valve. So it's not an easy procedure. There are some things that you need to consider. You have to properly predilate the septum. The idea to have a second body wire that we will learn from our colleagues. It's a good thing. It's not easy to advance, and then of course you have to remember to take out the body wire, otherwise you will interrupt it. So this is, I think it's a fine result.
Yes, we also measured the transvalvular gradient with the withdrawal of a pigtail catheter, and we had no gradient either during the withdrawal or on echocardiographic assessment, and we also had no LVOT outflow obstruction. And we also made a left ventriculopathy, and which did not reveal any evidence of regurgitation. And although the patient remained hemodynamically stable throughout the procedure, an intra-aortic balloon pump was inserted at the end of the procedure through the left femoral artery as a preventive measure against the expected afterload mismatch phenomenon. You can see the pump here. It is inserted. So despite the excellent procedural result with no regurgitation and no outflow obstruction, the patient developed hemodynamic instability post-procedure. This included hypotension, increasing requirements for inotropes and vasopressors, rising lactate levels, and episode of non-sustained ventricular tachycardia. Due to this, veno-arterial ECMO was placed the following day, and fortunately, this led to rapid stabilization of the patient, and the ECMO was successfully weaned and removed after 4 days. The patient was gradually weaned off both mechanical support and inotropic agent, and was eventually discharged in good clinical condition and ambulatory. Pre-discharge echocardiography, as you can see, shows improvement in the left ventricular contractility compared to the immediate post-procedural study. And echocardiography follow-up of the patient at 1 month demonstrated excellent function of the prosthetic mitral valve and stable left ventricular systolic performance with an LVEF of approximately 30% with no outflow tract obstruction. So in closing, I would like to highlight a few key points regarding the phenomenon of afterload mismatch following mitral valve replacement. In general, in patients with chronic severe mitral regurgitation, the left ventricle adapts to a low resistance state as part of the stroke volume is ejected into the left atrium. Once the mitral regurgitation is corrected, either surgically or via transcatheter valve implantation, the ventricle is suddenly faced with a higher afterload, as it now has to eject entirely into the systemic circulation. This abrupt hemodynamic change can lead to acute LV failure, especially in patients with pre-existing systolic dysfunction, as in our patient. Recognizing this risk is essential, and strategies such as prophylactic use of mechanical circulatory support or careful afterload management may be required to ensure a safe post-procedural course. Thank you for your attention.
If I can make a small comment, so this is an example of the hard team work and discussion that Dr. Kofidis was advising before. So we discussed a lot with the surgeons how to deal with this patient. Initially, we tried to understand what kind of procedure had been done originally, because it had been done, in a previous hospital, and maybe Dr. Kofidis can elaborate a little bit on that. So it was, they placed a semiform ring, and then there are some neocordae, which I suppose that they were ruptured. And then we discussed with the surgeon, about the other steps, and we discussed also on the possibility to have an ECMO immediately after, or let's wait and see. So we decided the second, and of course they were ready, and the surgeons, along with Dr. Leontiadis, who was instructed not to sleep that night, and he came early in the early hours of the evening, and the ECMO was placed. So, Dr. Kofidis, what your approach would be in this patient?
Well, in hindsight, we're all smarter. But yeah, a few comments, maybe questions I have. First of all, congratulations on a close call. The patient did well in the end and left the hospital. Also, congratulations on making the early decision to go on ECMO when the patient was on the post-MV repair or replacement banana phase, which can be detrimental. Now, a question I have is, of course, being a surgeon on the indication. He was 46 years old? Or
yes,
young
43,
patient.
43.
43, okay. Just a few years out of CABG procedure.
Mm-hmm. Yes.
What was the immediately pre-op coronary angiography result? I may have missed it. Before you went in for the clip procedure, for the valve in ring procedure, was there a refresh coronary angiography, and what did it show? Were the bypasses patent, or?
Yes, all the bypass grafts were patent. And there was no restenosis of the stent in the RCA. So he had no ischemia. And
I think, yeah, so the idea of the surgeon, I suppose, because we read his review, it was, he didn't want to replace the valve. He just put the ring, writing that maybe this will open up the possibility of having a TEER procedure in the future. So my question is, would you do that? Maybe why do you place a ring, and then why don't you just refer immediately for a TEER procedure?
Well, I can't comment on the surgeon's actions or decisions because I guess here in Greece it's very difficult to get to operation notes from the last procedure. Okay, so that's the truth of the matter.
If you get it, sometimes.
Yeah, so they have,
It's
very marginal. Right?
Cryptography, you have to, read.
Or very short and so on. So, well, there are guidelines, or at least there are opinions on whether to replace or repair the valve, at least address the valve when you have ischemic mitral valve disease. The bypass has obviously worked, that's first step. And then on a valve that is moderately severe or above, he ought to do something for the mitral valve. We all know that ischemic mitral valve is difficult to repair, may require leaflet extensions, it may require an approximation of the papillary muscles with slings or bands. So I don't know exactly what went on in the operation theater when the surgery was done. I noticed that the ejection fraction before your procedure was already low. What was the progress of the ejection fraction in the last couple of years, and why didn't the patient want to have a surgical procedure? I mean, what was the heart team's decision? Would it be very high risk to do a redo surgery? Or?
So yes, so the patient was excluded by surgeons of our hospital, another hospital as well.
Okay.
So he was discussed thoroughly in the heart team, so we decided that maybe the TMVR was the only solution, because the patient was really sick. He could not, he had a New York Heart Association 3, a young patient, otherwise healthy,
yeah.
but severe heart failure. And actually he was before coming to us, he was checked in the outpatient clinics of the heart failure specialist as a pre-transplantation screening.
I see.
So, and we debated a lot with the transplantation specialists in our hospital. Just let's give this patient an opportunity, maybe he can get out of it. And I think we are happy with the outcome, because patient, I saw him 1 month ago in the outpatient clinics, so he was feeling well. Actually, he could climb 6 flights of stairs in our hospital, which for him, after 1.5 years of severe heart failure, this was a big thing. I don't know how we'll end up, but we checked with the scintigraphy, it's mostly scar. We don't anticipate big increase in the ejection fraction, but for the time being, he's doing a lot better.
Was his MR at the time of the bypass moderate or severe?
Supposedly it's severe.
Because there is at least one study we know well that when you do bypass and you correct or not a moderate MR, it doesn't make a difference surgically.
Correct.
So that's why probably they thought putting a ring versus replacing the valve if it was severe or doing something more drastic. I assume we don't know what they did, but yeah, that was easy. Yeah. Good. Yeah. Good case. Excellent. Well, I think we have concluded an interesting session. We'll take a short